Hello, my name is Wafaa Shehata-Dieler. I'm a professor of otolaryngology, audiology, and phoniatrics, and I'm directing the audiology and phoniatrics electrophysiology department in the otolaryngology clinic in the University of Würzburg.
Hello, my name is Heike Kühn. I'm a doctor of psychology and specialized in the diagnosis and therapy of hearing impaired. I'm also the CEO of the Comprehensive Hearing Center of Würzburg.
Well, at the next presentations, we are going to introduce to you our follow-up program for children with hearing loss. Since 2010, we developed a program for all children fitted with hearing aids and cochlear implants, in which we do a multidisciplinary evaluation and therapy for all children. So, our program for audiological, psychological follow-up for children with hearing aids and cochlear implant started about 6 years ago. And there are several people who are involved in this program. I'm just listing some of the names of the people that are worked within the program. As you all know, hearing rehabilitation programs aim at establishing the diagnosis of hearing loss and the beginning of the therapy as early as possible. Since newborn hearing screening has been established, it became possible to reach these aims very early in life. During the last few years, the average age of hearing aid fitting ranged within 2 to 6 months of life, and the number of children receiving a cochlear implant at or under the age of 1 year has been continuously increasing. Here you see the system that we are using for the newborn hearing screening in Würzburg. Since about 21 years, we have about 30,000 babies that have been screened with this method. This is a headphone with 3 integrated electrodes on it. It's called the Beraphone, and you just put the headphone with the electrodes on the baby's head, and then an automatized ABR measurements is carried on. As you all know, the goals of the therapy extend beyond just improving the hearing abilities. The final goal of the therapy is an optimal speech and language development. Other factors, such as general development, presence of other handicaps, and psychosocial factors influence the outcome. And parents' counseling and support has to be maintained throughout the therapy, which means we are applying the concept of multidisciplinary diagnosis and treatment. As you can see here, we have developed a booklet which is given to the parents at the beginning of the diagnosis, and in this booklet several informations are included which I'm going to explain later on. So every child is included in this program as soon as the diagnosis of hearing loss is established. The program includes information materials for the parents included in this booklet, multidisciplinary evaluation for children and counseling of the parents at regular intervals. The results of evaluation are documented in this booklet, allowing an easy flow of information among the different caretakers. The analysis of data collected help to detect and evaluate factors influencing the development of the children. So we have several evaluations intervals, beginning from the pre-fitting and then at the first fitting, 3 months, 6 months, 9, 12 months, etc., until the age of 72 months hearing age. Several disciplines are included in the evaluation, including otology, audiology, speech and language, pedagogic, psychology, and technical support. From 2010 till 2018, we have 233 hearing impaired children included in the program, 132 fitted with hearing aids and 101 fitted with cochlear implants. And here you see one page of the booklet which shows an overview of the different intervals with the time and the different evaluation sessions planned. So for example, the developmental psychological evaluation, we have one evaluation session at the beginning, and then the next session is at an hearing age of 2 years. Same with the speech and language pathology evaluation. The first evaluation starts at 2 years hearing age. Here you see an example of a page of one evaluation session where we write our findings here, and this booklet is given to the parents and they can show it to the pediatrician or other rehabilitation personnel, as said, to allow easy flow of information among the different specialists. Now let's take a look at our sample. For our hearing aid children, we have 132 hearing aid children. Here you see a diagram of the age at the diagnosis. You see that most of the children have been diagnosed at the age of 3 months. We have a median diagnosis age of 0.57 years, a minimum of 0.03 years, and a maximum of 9.45 years. And here's the age for hearing aid fitting. Again, you see that there is a peak at 6 months. There is another peak later on, which is usually concerned with the children that have a progressive or a late onset hearing loss. The median age for the diagnosis was 0.79 years. The minimum was for the hearing aid fitting was 0.79 years, the minimum of 0.05 years, and the maximum of 9.45 years. On this slide, you see the children with the cochlear implants. We have 101 children, and here on this right side you see the bar charts of the age distribution at first fitting of those children. As you can see from the bar charts that most of the children were fitted under the age of 18 months. And this later peak at the age of 8 to 9 years are usually late onset or progressive hearing loss or single-sided deafness children. On the lower left side, you see a pie chart with the distribution of the mode of amplification for the children. We have most of the children are implanted bilaterally, 44 children are implanted simultaneously, and 21 are implanted successively. 31 children are implanted unilaterally, and 5 children have single-sided deafness and implanted on the deaf side. Now, if you look at the questions that we try to answer using our follow-up program, first question is, what is the optimal way to compensate for the hearing handicap? Which means, can the hearing handicap be well compensated by the hearing aids? If not, how are the indications for cochlear implants or for electroacoustic stimulation? Are there signs of progression of the disease, which means will we have to change the device later in time if the child is using a hearing aid? What are the expectations for the hearing and speech language development? And how is the actual hearing and speech language development with the hearing aid and cochlear implant? Is there a discrepancy between the speech and language development and that expected from the aided hearing condition? If yes, what are the causes of this discrepancy? Further questions are there multiple handicaps? Is the child development within normal or not? If not, how big is the gap? Are there neurofunctional deficits? Where are the best rehabilitation set up for the child? How is the scholastic achievements? Are there any problems? Which school is appropriate for the child? Does the child need additional therapies like occupational therapy or physiotherapy? And what kind of support is needed by the family? The different disciplines, as mentioned before, we have the medical disciplines, which means otological evaluation with microscopic evaluation of the ear, neuropediatric evaluation, audiological evaluation, including subjective and objective measures and functional gain measurements, speech perception in quiet and in noise, localization tests, hearing aid and cochlear implant technical check, ears test battery, and little ears questionnaires. Further diagnostics include psychological speech development evaluation. This includes general development and intelligence diagnosis and neurofunctional weaknesses, and this Dr. Kühn is going to explain later. Pedagogic evaluation of the communication abilities, family and social aspects, educational psychology, which means measurements of learning disabilities, and phoniatric examination, speech and language evaluation. So, first, I would like to thank you for your attention, and I will give over to Dr. Kühn, who's going to explain her part in this program. Thank you.
Professor Shehata-Dieler has just presented our program for hearing impaired children. Now I would like to go into more detail on the diagnosis of hearing and language development. We are looking for the following questions. How does the child's individual hearing and language develop? According to the hearing age, as expected, can the language development gap be closed? Are the language development inhibiting neuropsychological functions? How can we clearly display and compare the results over the entire time? Which therapy, intervention, school are optimal? This affects the consultation with the rehabilitative cooperation partners. For this, we consider the essential language development important subfunctions. In principle, the general development is of importance. For the purpose, the developmental areas, as you can see here on the left side, are considered. Motor functions, visomotoric functions, perception, mnestic functions, cognition, attention and concentration, processing speed, and social emotional interaction. Functions that are specific to language development are then described in detail according to the previous sections. On the right side, we are looking, for example, for mouth motoric coordination, articulation, tactile mouth perception, and so on. You can see it here. Our methods are developmental anamnesis, clinical free observations, parents' questionnaires, psychological and speech and language development tests. Here you can see our test intervals as said before, and the various German assessment tools with abbreviations that are standardized for the corresponding age of the child. The psychological test procedures for general development and intelligence are always selected according to the chronological age of the child. The test procedures for speech development and first applied according to the hearing age, and later on if the child's performance has reached the age norm according to the chronological age. Because the various test procedures measure different functions, the subtests must be combined according to the specific functions. Here you can see an overview over the assignments of the individual test procedures to the development functions. For example, we use the Little Ears Auditory Questionnaire to evaluate the early auditory development, and the Wechsler intelligence tests for all specific intelligence functions. The standardization of the test procedures is sometimes very different. T-values, percentile ranks, IQ values or standard values. Therefore, the test results are divided into broader categories for comparability. We group the data into the following group according to the standard curve and the standard values of the various test procedures. We say under average, it's a red line, the lower average, rosé line, the average, the green line, upper average, the blue, light blue line, and above average, the blue line. To illustrate the individual development of the children, we use the following template. The development functions discussed are listed in the middle column. Performance clusters according to the standard data shown on the right. For the different differentiation by auditory age, we use rhombs, as you can see here, and for chronological age, we use circles. You can see it on the top. The individual survey times are displayed in different colors, as you can see here, from white to yellow and brown to black. I would like to show you an example of the individual evaluation of 2 children. The first child was simultaneously implanted bilaterally with cochlear implants. The initial process of fitting was made at the age of 0.78 years. The first investigation with the Little Ears Auditory Questionnaire showed a below average result. After 3 months, the child caught up a little. After 6 months, the auditory behavior was on the normal range. The language development is always in the middle to upper average range. The intelligence is also in the upper average range or even above, as you can see. We see a child who has the best basic intelligence for language development and has no partial performance problems. The second child has a mild to moderate hearing loss on both sides and is fitted with hearing aids. The first survey was conducted at the age of 12 months, the general development screening of currently inconspicuous development. The first language development was also not unusual. However, over time it became clear that the child's speech production lagged behind further development. Mouth motoric functions and articulations, as well as motor memory, were below or lower average, without otherwise good to above average performances. Even after 6 years, it became clear that despite intensive speech therapy the child has a weakness in motor skills. Therefore, speech dyspraxia was confirmed as a partial performance disorder. In conclusion, we were able to reach our aim regarding display and comparison of individual cognitive as well as hearing, speech and language development of the child over the entire time period, and we were accordingly able to influence the direct of the therapy for the best of the child. Moreover, we have ongoing research. We ask, to which extent is the population of the Würzburg program comparable to the epidemiological data in the literature? That's a question about the generalization of our results. Cross-sectional analysis of the individual test results of all audiological, psychological, speech, language assessment will be done. Longitudinal analysis of individual development process and influencing factors for all children. Thank you very much.